We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, doctor of physical therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Welcome to the podcast this morning. We are so excited to have with us Dr. Betty Delass, who's an absolute expert in rectus diastasis or Diastasis Recti, however you want to say it. We're so excited to talk about the separation that happens in anyone's belly, but particularly after having a baby. And she is an absolute expert in this. We are talking about all the truths, the myths, and how to actually restore your core after having a baby. So excited to address this topic. Such a huge need. I just want to share a few statistics, a few thoughts before we introduce her. Diastasis recti is one of the most misunderstood postpartum issues out there. There's so much information that's accurate, that's not accurate, and just misleading. And so many people don't know what to do. So many people think, oh, I just need to do some planks, strengthen my core. Many women are told it's normal. You know, just deal with it. You'll always have this type of belly. It's a mommy belly. Be grateful for it. Others are rushed towards fear-based messaging, unnecessary surgeries, things like that. But today's episode is going to reframe Diastasis recti as a treatable, functional condition that is not a death sentence or not an issue that's going to create for the rest of your life. So this conversation is about empowerment, education, the science behind muscle strengthening and bringing those things back together, because it is a condition that you can fix a lot of the time functionally. So we're so excited to dive into this. I just want to introduce Dr. Betty Delass, absolutely incredible leader here in Utah. She has just done such an incredible job with her clinics and her clinicians and serving the community, especially with this postpartum, women's health, anything along those lines. Just done such a incredible job. She is the founder and CEO of Reborn Pelvic Health. She's also on the board of directors for APTA Utah, that is really leading the nation's efforts in change with primary care, with prevention, with getting access for patients for care and things like that. So we're so excited to have her on. She also has got 13 years of experience treating pregnancy, postpartum, and very complex pelvic conditions. And if you're in the PT world, you understand that there can be some very complex pelvic floor issues, and she is the absolute expert in her practice at this. She's also a mom. She's an endurance athlete, an educator, and a national leader in pelvic health. She's on a mission to redefine the standard of care for postpartum forever. So welcome to the podcast, Betty.
Thanks for having me, Brad.
So good to have you here. What led you to postpartum care in the first place and women's health in general?
Yeah, great question. So I always had an interest in it, but there was always, quote unquote, someone doing that. And so I never got training or anything like that. So I was just an orthopedic therapist, and there's nothing wrong with being an orthopedic therapist. I think they're great.
Yeah.
And then I had children, and I was like, what is this?
Multiple children. How many kids do you have?
I have 2 children. They're 7 and 5 now. But like after my first, I was like, and I'm going to be real vulnerable here, I sneezed postpartum and peed myself all the way to my shoes. Like it was bad. And then first time having sex postpartum, also painful. And like running postpartum. What is this? Prolapse. Oh, and like, I'm just like, almost like a righteous anger, right? I'm like, what are we doing for women?
This is role.
Not okay.
What can I do to help?
What can I do to help? So, and then I went to a pelvic floor therapist because I'm a PT. I'll go to a pelvic floor therapist. Yeah. And I was giving Kegels. And
from the PT?
From the PT.
Oh, no.
From the pelvic PT. And I had a hypertonic pelvic floor. And I was like, this is not good.
If any of you, those who are listening to this, Kegels are good if you're taught how to do them.
One slice of the pie.
It is a very small portion. If you've been prescribed Kegels and you have pelvic floor pain, a prolapse, or any of these pelvic floor conditions, Kegels, the majority of the time, are not the answer.
Right.
So
they're kind of like a buzzword in the pelvic floor world, because we're like, you were prescribed Kegels and that was it, right?
Yeah.
And there's just so much more.
There's so much more.
So keep going.
Yeah. So I was like, this is not okay. Like, this is so not okay. One, personally for myself, but then like, what is every other woman doing out there? Like after having babies, and a lot of us have multiple, right? And so I went down the rabbit hole. I signed up for my first Herman Wallace course to learn about pelvic floor. And like immediately I walked in that door. I was like, oh, here are all my people. There they are. And like dove headfirst in. So I took all the courses, all the things, learned all the things.
And just so you know, those who don't know what Herman Wallace is, Herman Wallace is kind of, I would say, one of the top gold standards for pelvic floor additional training. So when physical therapists come out of school, the school that I went to, the University of Utah, had a women's health course, which is just a semester. And part of that course, we did internal exams for one lab, which is a vaginal exam, where these, bless their heart, female women that were super passionate about pelvic health came in and would allow 30 students, I think probably only 15, it was optional.
Yeah.
But 15 opted to do it. But you can imagine getting a vaginal exam from 15 people that have never done this before in their lives. And you are instructing them on how to talk to someone that is having a pelvic exam, and be able to educate them and where to put their hands, right? How to touch, like all these things. But bless their hearts, so grateful for them. But in the PT world, you don't necessarily have to have additional training. People can come out of school and just do pelvic floor therapy based on their training, because it's an all-encompassing program. That said, this additional training is absolutely vital for understanding the pelvic floor. And I just want to tell a story, because you said Herman and Wallace, and it made me think of, I took my first Herman and Wallace course, and I was the only male.
Yep.
And I got to tell this story because I have never in my entire life felt more uncomfortable than walking in that room of 30 women.
Where I was like, there's all my people.
Yeah, you're over here. There's all my people. And I'm like shock. I'm literally in shock. All these women are staring at me like I'm a pedophile. And I was just sitting there like sweating. I was sweating bullets, and I'm very confident. I'm like, this is no big deal. But I couldn't swallow. I couldn't breathe. And they said, all right, they did the first section. Everyone's separated. They say, get a partner. Everyone's separated. There's 31 people. And of course,
you don't have the partner.
I didn't have the partner. So I'm just kind of reading the room. I'm really good at reading people from a distance. Everyone kind of turns their back on me. Like literally like, nope, not getting in our And it was so funny. But then these two gals, you could tell they were both moms.
Yeah.
And they were just very open. They were facing me. And I walk over and I'm like, can I join your guys' group? And they're like, yeah, jump in. And that really like helped me feel super comfortable. And we started doing our first exam on each other. And I just told them, guys, I am so nervous. Like I am so out of my world right now. The only reason I'm here is because my wife had a pelvic floor issue and no one could solve it. And I want to understand how to help solve these complex things. She was treated, for a hamstring strain for almost 3 years. She wanted to amputate her leg. She was so frustrated, saw so many providers, and was just never could figure it out. And then we found out it was her pelvic floor, and that's why I wanted to do it. And I was so uncomfortable. But now, like, I was so grateful. I think every PT, in my opinion, should go through at least one Herman and Wallace course or a pelvic floor course, just for differential diagnosis. Even if you're not treating pelvic floor, understanding the complexity, but also the simplicity of how the pelvic floor ties into the back, how it ties into the hip, how it ties into the hamstrings, right?
100%.
Because most of these things, we're treating back pain, but it's a pelvic floor problem, right? And just taking a basic course can help you identify that's not back pain. That is pelvic floor pain. Let's get you over to Betty to work on that, rather than me seeing you for 3 months and then you're not better and then they're just frustrated, right? But being able to guide to the specialist in that area is so crucial. What are your thoughts on that?
Absolutely. I 100% agree. I like to tell people like I'm a PT, I'm an orthopedic PT, and I'm a pelvic PT. So I'm the nerdiest nerdest of nerds. And I do believe that everyone should take at least one course to know enough to be dangerous, to be like, I know where to refer and who to refer to, because we all can't be specialists in everything. And so I think it's really important to specialize in the things that you're specializing in, and then have colleagues and collateral places to refer out, and to be able to help the patient with like the right provider at the right time for the right kind of care. And then the patient wins all the time with that.
Yeah, so. Absolutely. We really need to understand what's in our wheelhouse and what's not, right? We have specialists in neurologic PT. We have specialists in vestibular, which is balance. We have specialists in pediatrics that deal with very specific pediatric things with babies, you know, because there's orthopedic conditions that teenagers can have. Technically that's pediatrics, but that would fall in the orthopedic world, or could fall in the pediatric world, depending on the complexity, right? Or pelvic floor, right? But there's so many different specialties, and most PTs are generalists, which means they've been trained in everything, just like a primary care physician. But then there's also specialists in PT as well.
Yep.
So tell us how becoming a mom, you addressed it a little bit, but how did becoming a mom really change this for you?
I think it just lit another like fire in me. Like I had fire in me, but I think it just like elevated it to the next level. I call it a righteous anger. Like got angry about like, okay, I'm here for a purpose and I'm going to change something about it.
Yeah. You talked about like, you got leakage, you got pain with sex, you have, you know, you feel heavy, you know, you could call that, you know, a portion of prolapse, right? Like these symptoms that you learned in school that are correctable, but then now you have them. But yet you're realizing in our medical system,
there's gaps.
Who is helping me with this, right? It's like, oh, you're cleared 6 weeks from, you know, your OB. Like, go back to exercise. You're good, right? Your sex is good, but you have all these issues. It's like, okay, where's the gap? But in your clinical mind, you're like, I know so much, right? But what about people that don't know?
Exactly.
Right? So tell us how that lit a fire for the people, like lit a fire in you for all these patients that are underserved in our medical system.
Yeah, I think it goes back to like each person matters, right? And so when a patient walks in, you're like, okay, what's going on? What are we going to do? What are your goals? What are you having issues with? And being able to meet them where they're at and show them that there is a pathway, there is hope, there is healing, and that you don't have to just live with this or take no for an answer. Like, oh, that's just the price of motherhood, or, oh, that's, you know, my grandma had that, it's genetics. And so I think it's empowering people and ultimately just changing their life for the better, right?
Yeah. What do you feel like we're just going to use the word broken in our medical system for our moms? What do you feel like is, give us like your top priority, like if I could fix 2 things in our medical system for our postpartum women, what would it be?
Mental health support.
Okay.
And then
what would that look like?
I don't know. I'm not a mental health therapist, but I think.
But what resources would be really important in your mind?
I think prevention, obviously. Okay. So like both from a pelvic PT standpoint and from a mental health therapist standpoint is like, can we get with these people further upstream during pregnancy, have the conversations, have the screenings, have some information, and then again, assess.
Are they screening for mental health in the OB offices? Do you know?
That's a great question. They did with my second in the pediatrician office, which I was very impressed with. I was like, okay, good. So this is progress. After postpartum for me.
So not during your pregnancy?
No.
Okay. Because the OB office that my wife is in screens that very heavily. So I'm wondering if it's just not universal.
Now. I think I think that trend is happening. We also screen now? 7 and 5. So my first one, nothing. Second one, pediatrician.
So maybe it's just not universal. Like you know, all the offices aren't caught up on it.
And I gave birth in 2 different states as well.
Oh, okay, that's fair. Yeah, different states.
I've lived in like 7 different states.
What states were both of your children born in?
Fun fact, we're all born in different states. So Evelyn was born in Idaho and Jackie was born in Nebraska.
Okay. So yeah, that could definitely elicit some differences. Okay, so definitely some mental health screening, but then also resources during pregnancy that mental health issues is common, and we have resources for it. Here are the resources.
Yep.
Okay, I love that.
I think those things are really important.
What's number 2?
I think biasly, physical health of that, right? pelvic floor therapy. Because if you were to have a knee surgery or a shoulder surgery and you know this musculoskeletal event is coming up, when would you start rehab? Before, right?
Yeah.
And then you would prep for the event, the change in your body, and then you would start rehab again right after. But like growing a human, maybe even multiple times, is the biggest musculoskeletal change you'll ever do as a female. And so why are we not supporting that?
Absolutely.
Right?
What do you hope would change in our medical system specifically for our postpartum women?
I think that it should be more upstream. So coming in preventative wise. So come in when you're pregnant, make sure you're getting educated, know where your body's at, and then advocate for yourself for that. You don't have to wait for a referral. You can just go to pelvic floor therapy. And then again, postpartum, be proactive about that, of getting back to recovery and recovering well, just like you would after a knee surgery or shoulder surgery or things like that.
I love it. So you're saying people go to pelvic floor therapy during the pregnancy, so they understand the mechanics of their pain. They can manage their pain well and not get worse, and learn so much about the birth process and what postpartum is going to look like as well.
Absolutely.
How do PTs play a pivotal role in that process? What are like the big things? I know there's just so many in your head right now. It's like, okay, what would be the most pivotal things? But if you were to pick like 3 things that PTs play a huge role in both pregnancy and postpartum recovery, what would you say?
Yeah. I would say that getting mom's body in a very good position for birth. So like, are the things moving the way they should? Does pelvic floor move? Do the hips move? Does the low back move? Do your SI joint move? All of that stuff needs to move for baby to come out. And so making sure we're optimizing mom's body so that baby can get in a good position. Pelvic floor wise, we do a lot of making sure pelvic floor can get out of the way. Do they know how to reverse Kegel or relax their pelvic floor? Because your pelvic floor does not push your baby out. Your uterus does. And so educating on perineal stretching and mobility and being able to push prep with all of that in multiple different positions, whether you're on your back, your side, squatting, standing. Like, women give birth in all different positions. And so we go through every single position, open glottis, closed glottis. So like either holding your breath or breathing out, because when birth is unpredictable and when you're in it, it's like, okay, here we are and this is happening. So you have to be able to have tools in your toolbox to be able to deploy. And so I think it's important on those fronts during pregnancy, and then postpartum, kind of bridging that gap is getting the learning curve out of the way. So like, how do I activate my glutes? How do I activate my pelvic floor? How do I activate my core, my breathing? Because when you...
all these compensations that people develop.
Happen so much. And so postpartum isn't immediately like your computer plug is ripped out of the wall. And just like a knee surgery, your quad is inhibited. So postpartum, your glutes are inhibited, your low back, your core, your diaphragm's been shoved out of the way. So you have to reconnect all those things back, plug that computer back in and get it back online so it's working. And so life doesn't stop right after you have a baby. You still have to pick up that 10-pound bowling ball. You still have to pick up the car seat, which is more.
Don't lift up anything more than 5 pounds. But you have kids.
And then you have a 40-pound toddler that you have to also pick up and put in the Costco car seat. Like, Costco.
You just said so many incredible things. Oh my gosh. Like, we got to unpack a little bit. I know we're talking about the separation in the abdomen today.
We haven't even got to that.
We're going to get into that, and we're going to get really deep. But you just said some incredible things about what women need to know during pregnancy and after. You know, I really just want to spend a moment on teaching people to let their pelvic floor get out of the way. Again, you said uterus's job is to get the baby out. What does it mean to let the pelvic floor get out of the way?
It needs to lengthen. So I don't like using this analogy, but it's the common analogy, right? The bicep analogy.
Yeah.
Kind of combine that with like a trampoline analogy.
Yeah.
So when your pelvic floor is contracted, it's in an elevated state and it's tight. When you relax and let go, it opens up and stretches. And so we want that to be extensible so that baby can come out. If you have a tight pelvic floor, it's going to be harder for baby to come out. You might have more tearing, baby might get stuck, heart rate, like all different things can happen. And so I think it's important to know, like, you don't need to do a million Kegels when you're pregnant. You actually need to like relax it and let it move out of the way. Another important piece too, and this will tie into the diastasis recti, is you need a strong core too, because you also use your core to help substitute the uterus to push the baby out.
And I'm just going to put this out there and you jump on board with it and maybe even correct me. But the majority of people that have babies, in the way, I'm not going to fault nurses, but the way that nurses are teaching how to push are completely incorrect. So if someone is holding their breath and they're saying breathe in and push, right? And you see in the movies and holding the breath, teach us what that does.
Well, there's a couple things there. So like I swing on the fence both directions because I'm also the pelvic PT that gave birth on her back with a closed glottis. Yeah. So I'm like, that's just what happened in the moment, even though I prepped for the other way. Yeah. And so I think it's important that people have tools in their toolbox to do all of them because the strategy might be different in each moment. So I don't want to bash either direction because I think there's a lot of Kool-Aid both ways. And, there's important parts where it's like this technique might work better for this person at that moment. And so everyone's doing the best that they can with the knowledge they have. And same thing with like positioning and knees in or knees out and like all the things like that. There are like better ways on paper, but like from a personal experience, I did everything opposite of what I wanted to do. You know what I mean?
Yeah.
So.
But what I loved about like what you just said is you came in with a plan. Yeah. You have all this knowledge. And the individual circumstances in the moment are going to change that, right? And that's totally okay. You know, every one of my wife's deliveries, all 5 were different. Yeah. Like they were so different. You know, our last, one of the first ones, she has very shallow hip sockets. She had a epidural and some of the providers were pushing up on her knees and had a dislocation of her hip and really created a lot of hip issues because she's completely numb. She doesn't have any control of her limbs. And then as she pushes, we have people pushing up on her knees, which are pushing her hips out, right? And causing a lot of strain on those ligaments. And she doesn't know because everything's numb, right? And she was on her back and delivering on her back and doing the whole hold and push. This is before I knew anything, right? And we just have to learn, right? But what are the good, better, and best ways? Really, the good, better, and best ways are the most customized to you. And learning what your body is capable of, learning about what you want, like what your desires are, but most importantly, teaching you how to control your body. What is it like to fully relax your pelvic floor? What is it like to use your abdominal muscles to push the baby out and help the uterus? What it's like to control your breathing and stay in a calm state as much as you can.
And I think those are the most important pieces is like connection with your body, practice ahead of time. So you know, okay, I know what this feels like or what I'm going for, but know each of those different along the whole spectrum because you might have to pull this out over here, but you might also get this.
Because ultimately, all those providers that are with you are their number one priority is to make sure you and baby are safe. Right. So, do we care as much about breathing when we're thinking about safety? No, you get that baby out.
And for example, my first was almost an emergency C-section for that. So it was like, you better get this baby out now. I was like screamed at, and so I was like, you know, like
whatever it takes,
everything thrown out, you know.
Yeah, and the goal is to stick to the plan as much as possible, but then also be okay with the change of the plan too. Your providers, the providers in that room are there to make sure you are safe. And as long as you have a good plan with them, they're going to try to stick to that plan as much as possible, as long as you're advocating and you've educated and everyone's on the same page before. And then when game time happens, you really got to trust the people in that room to guide you. You know, and having those conversations before are super critical. You have to trust your providers.
Absolutely. And that's the most important part.
Yeah.
Trust the providers. It goes much better.
Yes, for sure. Okay, let's dive into diastasis recti. What is it? Define it for us.
Yeah. It's the separation of your abs that happens during pregnancy. 100% of people will have that happen if they make it to term. And it's normal. I think there's a lot of fear mongering out there of like, oh no, diastasis, I have diastasis. I'm going to get diastasis. How do I prevent it? And it's like, you don't.
It's like a diagnosis like back pain, right? It's like you got back discogenic pain the rest of your life or, you know.
Yeah.
So tell us, you said 100% of people get it. Why do people have why do some people have separation after having a baby? And why do some people don't?
I think we're still learning and investigating that. A lot of the narrative and the research is evolving. And so there's been a lot of recent updates with research on that. And I'll dive into that a little bit. But what happens is when you're pregnant, you have more type 3 collagen in your tissue, which is the extensibility stretchiness of it.
I think it's very elastic,
yeah,
right? Like
stretches.
a rubber band.
Your body's meant to stretch there.
Yeah.
And so the middle piece there is called the linea alba between your two six-pack muscles. And so that is meant to stretch during pregnancy to accommodate baby. And so otherwise, where would we go, right?
Yeah.
And so you have more type 3 collagen. So the people who have also more type 3 collagen, the stretchy stuff throughout your whole body, they usually rebound a lot better because their body's just stretchy in general. So they're able to stretch everywhere, including that middle piece.
And typically you're going to have more of that type of collagen when you're younger, right?
Mm-hmm. Yep.
And as we age, that collagen changes.
Yep. And so even like think about the hypermobile people too, they have more of that collagen as well.
Yeah. So if you have a lot of elasticity or a lot of movement in your joints, so you can hyperextend your elbow, that would be what you're talking about,
exactly.
Right?
And then I think I take a lens of like, it's a system problem. So I'll use my shirt as an analogy. If everything's really tight in the back, all your muscles are really tight in your back, it's not moving well, there's no other place for it to stretch but that middle piece. But if everything back here moves like it should and everything like that, everything can move. And then that middle piece doesn't stretch as much. And then even going a layer deeper, there's some newer research out with like visceral mobilization, and visceral is your organ mobility. And so a lot of the back wall of your organs, if that doesn't move well, can cause more of this because everything's connected through fascia. And fascia is that spider web material over your body that holds you together and stretches, that has the collagen in it.
Yeah. What causes that fascia, those fascial layers to essentially adhere to each other?
It could be anything from repetitive trauma, like sports wise, of like constant falls in gymnastics, or, same only swinging a bat one way, or things like that, where it's just like,
there's certain movement patterns that you've developed throughout your lifetime.
Yeah.
Because I love that you use the swinging a bat one way, right? Our bodies learn to move based on the demand we place upon them. So if we're moving and we're rotating it, we could say excessively, if you're batting on the one side consistently, what happens to the rotation on the mobility going the opposite direction? Right? You don't work that side. So you develop some compensations throughout a lifetime that can really limit your ability to move the opposite direction. Right.
Yep.
So tell us, so we talked about the definition. I love how you said it was normal. Some people say, well, it's common. It's actually normal, right? What causes that gap afterwards?
So your body has stretched to accommodate, and then it rebounds and comes back. Most of the time, most cases, it comes back together within a normal range.
So your two ab muscles just kind of come back together.
Yep.
And does that scar down? Does that heal? What does that look like?
Not necessarily scar down, but that your collagen changes back too. So another important piece to layer in here is postpartum, you get into a de-estrogenized state, especially if you're breastfeeding. And so that helps, quote unquote, stiffen your tissue. And so that can be really important for hardening of the fascia in that area. And same thing with prolapse too. And so
breastfeeding can be very helpful for those types of things.
It's proactive for those types of things. I think it also depends on the demand. Like, did you have triplets? Like, that's a whole different ballgame. You know what I mean? I would never fault anyone for like, I think I need a surgical repair for this. Like, you probably do.
Triplets?
You had triplets.
That was a really large belly.
Yes. Yeah. And so I think too, we're learning now with the newer research that it has to do with also the strength of your core too. So we've taught a lot, like because of so much of the fear mongering, it's actually creating a worse problem because people aren't using their core when pregnant, or they're fearful they're going to make their diastasis worse. And then also our own profession is at fault too, because we're like, oh, just do TA things, do TA, which is
not progressing it.
Which is just your transverse abdominis, which is the corset that wraps around across your belly versus your six pack is up and down.
Yeah,
and so
if you need to kind of like picture that, just Google it.
Yeah.
Transverse abdominis, you'll see, and go to images, you'll see how it literally looks like a corset. And you're saying that our profession is guilty of saying just squeeze that muscle
because they're so
and
concerned
we lack
about
the progression.
Yeah, we're so concerned about not making the gap go wider and not doming. But actually what happens during pregnancy is your mechanics change biomechanically in the belly. So normally when you're not pregnant, your rectus is your anchor. When
and we're
you're
talking
pregnant,
the abs, right?
Yep. So your six-pack muscles, rectus abdominis, is your anchor. And then when you're pregnant, that widens. But then if you do TA, what does TA do? Makes it wider.
Yeah, because you're
TA
contracting
pulls
that muscle.
this way instead of we should be focusing more on rectus.
So most providers are thinking that the muscle actually contracts this way, right? Help us with that gap that PTs are misunderstanding there.
We're not lensing through the mechanics of what happens, because instead of being straight like this, now it's like this. And so we're saying, oh, let's do TA, but TA contracts this way. It doesn't contract this way. Rectus actually contracts this way. So we shouldn't be shying away from other core exercises. Like, we need to incorporate the entire core. And then it even take it another layer further is like, we're finding research now that like, if you have the weaker your core is going into birth, the more likely you are to have SPD, the more likely you are to have SI joint dysfunction. And it's like, oh, this is a huge problem.
Yeah. Tell us tips for the listeners. How do they know if their core is strong or weak? How do you measure that?
There's a lot of ways we can measure it in PT, like,
yeah,
things,
give us like some tips for just a mom at home that she's like, I don't know if I need to go to PT. You know, we could argue everyone needs to go to PT, right?
Like, oh, how do I do that?
If they're like, well, I want to see what level of priority this is. I think I have a strong core. What could they do to help identify if it would be absolutely necessary for them to go to PT, or if it would be like, it'd be good for them to go to PT?
Oh, this is a hard question. I'm like, how do I answer that? I would say, there's a couple things you could try. Can you do a plank? And then can you do a leg lower? Like on your back, legs up in the air, lower them down.
Both of them at the same time? Or one at the same time?
One at the same time. Either one, whatever. And just see, like, can I have my legs go 45 degrees or further down without losing my low back on the ground? Can I hold a plank for 30 seconds to a minute? If you can't do those things, then it's like, I probably have a little bit of weakness or something that I can refine in there and work on that. If you have any pain with any of that stuff or pain in your back, of course, there's like, you should probably come in. Like, there's more to it to unpack to figure out, like, why do you have back pain? It might not be a weak core. It could be something else.
Is there certain mechanics that they need to be looking for with a plank? Is a plank, or is it, they need to be able to hold their pelvis in a certain position with a plank, a full plank, a plank on elbows? Kind of break that down for us.
Plank on elbows, plank on hands, fine. But you need to be in good alignment from head to
not
ankles.
Sagging.
Yeah, not sagging.
Not up in like a pike position, but kind of just
And you'd be
flat.
surprised how many people don't know how to do a correct plank.
And you're saying what period of time would you say? You said 30 seconds.
30 seconds to a minute. If you can do that and you're able to engage your core, you feel strong and stable, and you're in good form, then you probably have a decent core that's working.
And then what about the leg lower? Is there any mechanics there? Are we keeping the back flat? Are we, putting hands underneath the back? How could they measure that?
Yeah, no hands under the back flat, and then just lowering legs down. Can you get past 45 degrees and without arching your back, holding your breath? Like,
those are great tips, just to like a quick measure, just a quick assessment at home, look at it. Give me like 2 things that you look for in the clinic that on top of that to determine if someone needs the core strengthening prior to pregnancy.
Great question. I would say that we're looking, and I don't love the word strength. I'm more of a stability fan.
Yeah, I like that.
Yeah.
Me too.
Of like, what is their stability look like?
Because people are like, oh, I just got to be strong.
Yeah.
It's like,
but strong and stable are so different.
Yeah. How many people have you seen that have a ripped 6-pack, but they are not stable at all?
Yeah. And I'll throw my husband under the bus on that.
Because
he's not here. And you might not listen to this, but that's fine. He was well aware of this. He was a professional soccer player. And when I met him, we were working out together. I'm like, okay, let's do some core work and stuff like that. I'm like, what is this trash? Like, so he's very, very strong. Yeah. But he was not stable underneath that strength.
How would you define that?
I think the compensation patterns, right? It's like, okay, I'm using my muscles, but I'm like arching my back, or I can run really fast and pivot, but it's all coming from my hamstrings and not my glutes.
Yeah.
And so I was able to, because I'm a PT, identify some of those things, untangle it a little bit and be like, oh, tweak this, change this, and just changing like a pelvic tilt into it. And he's like, oh my gosh, I'm just destroyed by abs. Yeah.
When you neutralize that pelvis position, you're essentially taking the compensation of certain muscles out of it and forcing the load through the kind of deep core muscles.
Deep core, yeah. So he was using his superficial muscles to do all the work.
Talk to us about superficial versus deep muscles though in the core.
So a lot of people think like core is just the ab muscles, but it's also your low back multifidi. It's also your glutes. It's also your adductors that help stabilize in. So there's so many pieces that everything that attaches to your core is your core. So lat muscles. Yeah. So it's a whole combination of things. It's not just like, oh, I can do a crunch and just use rectus.
Yeah. A lot of people think just the six pack muscle, that's my core. Right.
No.
But the six pack muscle only does a linear pattern. It's just trunk flexion, right? Or trunk extension with, a lengthening of the muscles. But there's so much more. If you look at the complexity of the musculature around the ribs to the pelvis, there's so many that cross over and develop that control. We can just talk about one compensation. If you're doing like a single limb stance, and you can totally use your back muscles instead of your glute muscles to stabilize your pelvis, right? And we're talking about stabilization. We're typically talking about the glute medius and some of the rotator muscles in the hip being able to keep the pelvis still without compensating through the low back muscles. But some people will use their low back muscles and develop power because those are the big muscle groups, but the small muscle groups aren't able to keep the hips stable. Right? Is there anything you'd add to that?
No, but I think we're looking mostly at stability, because a lot of people have quote unquote strength, or they can do something, but it's like, what's underneath that? And you need a solid foundation to be able to build off of that, and also not have pain or dysfunction created from that as well.
Yeah, absolutely. Is there any measures that we could use to help people identify if they have, or even just things that they would notice if they're strong versus stable?
I don't know that I have any like magic wand for that, and I know this is what you didn't want me to say, but
no, totally.
I think that's really
where.
But
tell me why that's complicated.
It's complicated because I think people aren't as in tune with their body as they think they are. Yeah. And so our favorite thing to do when you come into Reborn is we want you to be the expert of your body. Like, you come in and we will most likely be the expert of your body at first, but by the time you're done, we've translated that information, that education, that empowerment to you, helped you understand how all the pieces come together so that you can on command be like, I know with conviction that my glute is on, or I know that my deep core is on, or I know that I activated this muscle and I'm stabilizing the way I want to. Where before, when you came in, you'd be like, I think I am. I don't really know. Same thing with the pelvic floor. I think I'm doing a Kegel. I don't really know. So we really make that connection so that your mind and body are really solid on that. And that's like the best part about coming to see someone like us or a physical therapist in general, is like, you're going to be the expert of your body when you leave. Yeah, absolutely. There's just so many compensations people can develop, right? Even just something simple as a single leg hop. And they're not able to control their knee, right? Yep. The outside of the hip is really the stabilizers, the deep stabilizers, small ones. And you could be using your pelvic floor and your adductors on the inside of your thigh to stabilize the hip. Do all the work. Yeah. And do all of the work, when the outside of the hip, the big, the small stabilizers and the big muscle groups are supposed to be doing the work. But you could be having pain with sex because when you run, you have this compensation that you're overutilizing your pelvic floor and you don't even know it, right? Totally, yep. It's sometimes like, well, why do I have pain with sex? Yeah, sometimes the pelvic floor is trapped. Way, right? Yep. And the pelvic floor is just like guarded and it's consistently tight, right? And when we say tight, we mean not able to relax. And it's consistently working. And why do you have pain with intercourse? Because your muscles never relax, right? And it could be from the compensation from running. But to be able to explain that to a patient not in the clinic is really hard. It's really hard. It's like,
well, we got to look at you. We got to look at the way your pelvis is moving. We got to look at the way you're running, right? And we don't want to pick these things apart, right? I think our profession's guilty of that, like at some points, right? Like, okay, you squeeze that muscle. No, you did that wrong, right? And it just like makes people hyper vigilant about every little thing. It's like, oh, when I pick up this pen, I should be contracting this muscle. It's like, well, that is not the goal. Right?
Also not the goal. Yeah.
We don't want you to become overly obsessive about every little thing and how you pick it up or anything like that. We want you to just be in tune with your body and make sure the stabilizer muscles are stabilizing and the big muscles are doing the powerful work. You know, is there anything to add?
Ultimately, at the end of that, like you should be able to move without thinking about it.
Yeah. If you're graduating therapy, you should not have to think about these things anymore. You should be able to move with confidence and not even have to go, you know, unconscious or consciously thinking through the steps of it. Because a lot of times when we teach, it's purely to take you from the conscious to the unconscious, right? Consciously competent to then unconsciously competent to build that bridge, you know? So tell us why the gap doesn't tell the full story. If you're measuring the gap in rectus diastasis and you're like, they've been told from someone, you got a 3-finger gap wide and 3-finger deep. You know, they've just heard it from someone. Why does that not tell the full story?
Doesn't tell the full story because it's not showing the function of that muscle. So like, can we get you in a functional contraction? Can we put you in a plank? Can we get you lifting a load in real day life things? And you might actually be very functional with that 3-finger gap.
Tell us what functional means for those
so
who
be
don't
able to lift your child up and put them in a car seat or into the Costco cart or into the bath or whatever you're doing. Can you engage your core properly where you're not having pain, you're not having dysfunction, you're not breath holding, and you can make that happen without those compensations that we've been talking about, right? And so it's more of the compensations then lead to the dysfunction.
So someone could have a 3-finger gap and
totally fine.
Be totally fine.
Yeah.
As long as they don't have pain, as long as they can lift fine.
They can contract their
They're
core
not
appropriately.
leaking.
Yeah.
Like it's not really an issue.
Yeah, totally could be.
Yeah.
And the next person could have 3 fingers and have all of those other things and be the opposite side.
Yeah. So as a clinician, does this need to close for people?
No.
Tell us why.
It doesn't need to close because the width does not equal the function. So like anything 2 fingers or less is quote unquote normal and functional. 3, you can get very functional. We can maybe even close that a little bit. But once you get beyond 4, 5, 6, 7, like there's structural change that's happened. So those would be the things of like, can we improve this to some degree? Can we strengthen you as much as we can? But there will be a ceiling in that of like, what can we do conservatively? Like,
yeah. And why is there a ceiling? We're talking about the linea alba, literally some connective tissue. Why is that?
It comes down to genetics, like how much type 3 collagen do you have that we talked about? How big was the baby in the belly or how many multiples were in there? And so maybe you do need surgery to functionally bring that back together. And you need rehab before and after that too, if you're going to do that. And then the other pieces too, I want to kind of tail a little bit to another direction is we can also do things outside of just that gap that will close the gap in like a session. So like we can dry needle your rectus, we can dry needle your obliques, we can dry needle your low back and your lats. And all of a sudden,
these are all core muscles, right?
Core muscles, yep. And all of a sudden, at the beginning of the session, you were 3 fingers. And at the end of the session, now you're 2 fingers and you have better engagement because you have better mobility from other places.
Yeah, because there might be like a holding pattern because you had trauma, right? Because trauma typically either will turn off, inhibit some muscle groups or overactivate some, right? So it might be that you're just holding in certain muscle groups that we need to relax them. It's like, well, yeah, I have the separations, but I also have this back pain.
Yeah.
Like,
and we work over here and all of a sudden this changes.
Yeah. And it's so incredible. And that's why it's challenging to just teach this over a podcast or just give tips and tricks over the internet, because every person and their compensation is very different.
Yep.
Your trauma, and we're just going to label it as trauma. You had a baby, pelvis splitting over. It might not have been a traumatic experience for you, but it was for your body. And we need to treat it as such, and we need to rehab it as such and reteach those muscles and your body to work at full function, you know, and then we compound multiple kids on top of that, right? And then it just becomes more and more complex.
Yeah.
But okay, going back to diastasis recti, how do you measure it in clinic?
So the standard way to measure it is you lay on your back, knees bent or legs straight, and you take 2 clinician fingers on the belly button, have them lift their head, contract their core, and you're measuring the distance and depth.
So you go right at the belly button.
And then a little bit
and
above.
You're going
straight in.
Straight in.
Yep.
With your fingers at which direction?
So if this is the belly, straight
down.
Yeah.
Okay, so you're measuring the width of between the rectus muscle, your ab muscles.
Yep.
As you do just a head lift.
Head lift. Yep. And then we go a little bit above the belly button and a little bit below the belly button to see if
just like a centimeter, an inch. How much are we talking?
Yeah. 2 inches.
2 inches. Okay.
Yeah. And then, I don't follow like the book on that stuff. I'm like, okay, here's about the belly button, and then like what's happening. Like I'm measuring the whole thing of like what's.
And should it rise?
It should
dome,
close.
or should it close together?
Closing, but like more and more research is finding out like none of that really matters.
Yeah.
So it's like all the things we've been doing is like
we've become so obsessive about the separation.
Yep.
And so much of it just doesn't matter.
It doesn't matter. Yep.
Yeah,
so
I love it.
I don't want to put too much emphasis on like measuring
because
it.
The thing is like we get obsessive about that space, but if you don't have any issues because of that space, it doesn't really create any issues for you later in life.
No,
right?
Not necessarily.
Like there's no correlation between that and causing issues in the future.
Yeah.
Right. So tell us. So you measure it, and then how do you grade it?
Centimeters, finger widths, like generally.
How would you like document or tell the patient like, hey, you have a what?
I'm very careful with my patient language on that of like, because we do get a lot of patients that come in and like, I think I have diastasis recti. Can you measure? Can you tell me? I'm like, okay, no problem. So we'll like do it. And like,
and you try not to be dismissive because you're like, in my mind, it really doesn't matter, but I'll measure it because it's important to you.
Yeah, it's important to you, but then use it as an opportunity to educate too of like, actually like it's pretty normal. Like I wouldn't say that you have diastasis recti. Like, what? Really? This is incredible news. Like they're like so relieved. And even if they do, I'm like, oh, just a little bit of a separation.
So you really don't go
like,
into like, you have a 3-finger depth. You have a 3-finger width.
Unless it's like blatantly obvious and we've been doing like the work and they're coming in like, I think I'm going to need surgery. I want to see if that I can prevent it or whatnot. And like, we're going to give it our best go. But like, at the end of the day, I need an honest clinical conversation with them too. Of like, you had triplets, you have a 5-finger separation. We've worked on it for a couple weeks now and nothing's changed. This might be something you want to consider in your path. So
if someone comes in and they only have diastasis recti, they don't have any pain, it is very concerning for them, and they want to treat it.
Yeah.
Let's just walk through a few steps, some just tips, kind of a recipe for people. And keep in mind, if you're listening to this is not customized. This is purely just the sequential steps that we'll take to help in a progression. But the progression is going to be different for everyone. But walk us through the progression of someone that's coming in and they have a very large separation. They want to avoid surgery. They want aesthetically, they're just like, I really feel like I need to fix this in PT. What do we do?
We're going to assess them as a whole person, right? And we're going to look at other things because it could be like we talked about their low back that's tight. That could be influencing that. It could be some obliques that are influencing that. It could be their breath holding pattern. And so we want to make sure we're not missing any pieces contributing to that, even if they're just coming in for diastasis. We're going to look at their ab muscles in themselves. Do they need some dry needling in that to release some trigger points to let that close? We're gonna look at their core activation in multiple positions. How do they activate when they're laying on their back versus on hands and knees versus standing, and educate through how to do those things and then load them up with those things as well. Would kind of be like the progression through that.
Yeah. And there's some both truths and myths to, crunches and planks right out of the gate. Like say someone's, 2 weeks postpartum. Are they doing crunches? Are we prescribing those things?
That's where the narrative's flipping right now with all the research. It's like, actually, we probably should be giving crunches.
Yeah.
Yeah.
Tell us just give us some basics on when you would say crunches are appropriate and in planks and when they're not.
I don't know if I have an answer to that, because I think it's just totally depends on the scenario, right? Because again, going back to reality of mom life, like you're in bed, you have to get out of bed, so you have to do a crunch.
You can do a log roll and just
like you can log roll to only, you know, for a little bit if you've had a C-section, like you want to protect that healing until it's appropriate to do that, but in essence, like you still need to be able to crunch in life, and so we need to work back towards that. And I think not going like jumping full in is going back to the connecting that computer back in. Like, can we activate TA? Can we activate and do just a little head lift where we're getting rectus and progressing that load appropriately within the soft tissue healing stages, right? Like postpartum, you still have to respect soft tissue healing, which can take 6 to 8 weeks. And so you can progressively load that just like you would a knee or a shoulder strategically with maybe some isometrics, maybe just a like gentle movement, half the range of motion. You're not going to load it up with weight right away. So I think it's just... And
I love when clinicians, I used to hate when they say it depends. It's like, well, that's not helpful. All my professors would say, it depends.
Yeah.
It's like, well, why?
Yeah.
Tell me why it depends, right? And if there's anything I could say to kind of help people understand, even new clinicians or even physicians, like, why does it depend? I would say, well, why does it depend on the type of eyeglasses you get, prescription, right? Why do they go through the sequence of better, worse, same?
Yeah.
When you're getting your eyes checked? It's because it depends.
Yeah.
It depends on how clearly you see through those eyeglasses when they give you a new lens. And we do the same thing with exercise. We try something, see how it does. Okay, better, worse, same, right?
Yep.
And we're consistently switching and testing and retesting over and over and over until we figure out your customized lens.
Beautifully said. Yes.
Like, and once we nail that, then it's the clear lens, but then you're going to get better. And then we got to do the same thing with the next step, right? So it's so hard to just say, yeah, crunches are good for you right out of the gate, because it really depends, right? It depends on how you're compensating. Do you have low back pain? Do you have leakage? Do you have prolapse? Do you have pain with sex? Like,
what was your activity level while you were pregnant and before?
Yeah, like, were you doing planks before?
Were you running marathons or were you not? Yeah.
You know, like, I just want to really show the public how important it is to go to a physical therapist after having a baby, because there's so much that really depends.
It really
is. You know, that's why we went to school and got a doctoral degree, to understand the dependence, right? Like, we needed to understand that full picture. We need to understand all the anatomy and how it ties together and all those layers, and the brain and how it connects, and trauma and all of those things. We got to understand how back influences the hip, and hip influences the pelvic floor. And it, you know, I can't overemphasize enough. Like, I hope we've given you tips as you're listening to this that can help just do quick assessments at home, but also understand the importance of going to a pelvic floor PT during pregnancy, even before and after. And, you know, there are insurance limitations that we do our best to educate on. But at the same time, like, this is your life. This is your body. This is your
one car.
Yeah, like, if you're just like, well, my insurance only allows me X amount of visits, are you going to let insurance determine the quality of life you have because you don't have access to therapy, right? There's always access to therapy in more ways than just your insurance. What's most important is you get the care that you need.
Yes, absolutely.
Tell me about, I want to kind of wrap it up with this. The women that are like, oh, it's too late. It's been too many years.
It's never too late.
Tell me about that. I've had 5 babies.
Yeah. It's never too late. Your body is resilient. Your body wants to heal. Your body wants to work optimally. And sometimes we as humans don't know how to do that. And that's where us as physical therapists come in, because we can help be that guidance to that individually for you. Like, this is what you need here, here, and here. This is going to get you better. And like that then empowers you to make that progress. And for those that are like, oh, it's too late still. Like, the oldest lady I ever helped was 93. And she stopped peeing her pants after 8 visits. And she'd been peeing her pants for decades. And she didn't know that it was possible. So like, healing is possible. Your body wants to heal. Like, it's resilient. You can do it.
It really has an internal program, if you think about a computer, of healing, right?
We're designed to heal.
We are truly human beings that are designed to just start over and repair. And the reason our bodies break down is to repair. That's the intention.
Yep.
And it has this deep blueprint of healing as long as we give it the resources to be able to do so.
Yep.
So that's such good thoughts there. So last question for you. What is one message, let's just priority here. What is one message that you hope every postpartum woman knew?
That you deserve it. Like, you deserve to feel your best and be your best.
How many people have you told that and they just broke down in tears?
Probably every single person, because I'm also seeing them immediately postpartum.
I can't tell you how many women I've said those exact words, and I'm actually getting emotional.
I'm getting teary too about it. I'm like, oh.
As you say that, like, you are worth it.
You're worth it.
And every woman needs to hear that. You are worth it.
Yep.
You're deserving of it. We are doing our absolute best as healthcare providers to build a system that serves women. Women have been underserved. And I do want to put this piece back on women. You need to advocate for yourself. You need to talk to women around you. The reason why you don't get served is because you don't talk enough about it. You'll shove it under the rug. You'll shove it under the bed. And we don't speak about our problems. Having leakage, having pain, having these things is not okay. This is why our healthcare system exists, is to help you. But your voice has to be heard.
Yep. And I do believe the pendulum is shifting. Like, I think my generation, our generation, that is shifting, and it's becoming apparent because there's a huge need, and people are coming in, people are speaking it, people have heard of it before, where before in my parents' generation, it was like, oh, hush, hush, we don't talk about this, like, private information. But I think the help of social media, I think the help of our generation of like, enough's enough, like, we're not tolerating this anymore. The pendulum shifted.
Yeah, I agree.
So just keep it going.
I completely agree. And we got to keep that momentum in a very kind way, right? Like, but just having the conversations that some of these things are normal. A lot of them are very common. And what can we fix, and why is that important? I love all that. Thank you so much for those thoughts. I want to shift gears just a little bit. You are on the APTA board of directors for the state of Utah, making big impact and big change. And what we're doing in Utah is actually like creating a huge movement across the nation.
Yeah.
And it's so fun because we're the first one to pass this primary care bill. And if you haven't heard me talk about this before, it means that PTs are listed as primary care providers for musculoskeletal conditions. We're not prescribing medication. We're sticking to our scope, but what we are good at is pain. Anything pain and injury, that is our world, and we are dang good at it. But you just came onto the board.
Yeah.
And you've seen a lot of these legislative changes that we've recently been making. And I think you had our second board meeting. And tell us what we talked about in the board meeting, like what stuck out to you. Like, I'm sure there's so many things, like as a clinician, as a mom, as a business owner, like what are the key points that people should know that we're doing in our board meetings?
Yeah. Two things come to mind. One, just like the momentum that Utah has with the legislative things that we just did this last year. The nation sees it. Like, not just Utah, but like, whoa, we're watching Utah, like what they're doing, which is really, really cool. The second thing is like the primary care legislation to be designated as that, and then what that ripple effect can be. And so like this year, it's the fair copay stuff that we're trying to push, right? And so how can we make copays equal to primary care and make sure that we are seen in the payer's eyes as equals as well?
Because so many people have, a $40 copay, and it makes sense for a primary care physician. Well, no, it doesn't. But it makes sense for a specialist because you go to see him once, right?
Yeah.
You're going to go see a PT for
Multiple
12,
times.
14 visits.
Yep.
Your $40 copay adds up.
Yeah.
Right? Especially if you're on a fixed income, that's a lot of money. So what we're trying to do is get that copay from a $40 to maybe a $10.
Yep.
Right?
And,
because that's what primary care copay is.
And the ripple effect of that is massive. It's like you don't see it on paper at first, but if someone can come to physical therapy and be able to do a full plan of care, get better, they're avoiding MRIs, injections, surgery, which are way more expensive right? So then you drop the copay, they have better access, they get better care to the root cause, avoid a bunch of expensive things. The insurance companies, the patients, the healthcare system actually saves massive amounts of money on the back end of that.
Yeah.
And so it's huge.
So what would you say to legislators and these payers that are like, well, we're going to have to absorb a lot of those costs. It's going to cost us 200, 500 grand for the year if we pass this legislative piece. You addressed a little bit of it, but what would you say to these legislators and payers?
I would say it's similar to just like eating healthy food, right? Like if you put not healthy food in your body, you're going to have diabetes, you're going to have high cholesterol, high blood pressure. So you're going to add up expenses later. That's going to be way more of a problem to fix than if you just stay proactive in the front end and get to the root cause, right? And so if you spend the money now, or this cost, this associated perceived cost is actually way less by investing in eating the healthy food.
Yeah, absolutely.
And then you're not going to have this downstream healthcare cost.
And a lot of the legislators, as we've met with them, are now understanding this piece, right?
Mm-hmm.
The prevention piece we
It's
cannot
huge.
ignore.
Yep.
That's why we passed the primary care bill in the first place, and they were so supportive. They're like, opioid crisis,
Huge,
right?
massive.
Is so big. There's so many deaths that are coming from that. How can we focus on the prevention piece, right? How can we put you on the front lines to help a lot of these issues down the road? So what I'm hearing from you is
This is
prevention.
a piece of this.
This is a huge piece to save downtrends of money, right? If we can prevent all of this excessive healthcare spending, it will save payers so much money.
It will actually be true healthcare versus sick care, which is what we have, unfortunately.
Yeah, and we really need to shift our models, especially in one of the most progressive nations in the world. We need to shift our model from sick care to health care. Be about health, be about putting these things into our body that actually are going to create good change long term. I love that. And I hope everyone understands this copay bill is going to be the biggest thing that we've done since primary care. And that was done last year. But, there is just this huge shift in healthcare that's happening and is spreading across the nation. There are 4 states that I know of that are working on this primary care bill in their states. Once we get 26 states, that is critical mass, and that's when Medicare starts to really look at this and be like, it's all the states are really jumping on board. But yeah, this copay bill is huge. So if you are following any of this, or if you're not, please be a part of it. You can be a part of it by following legislative sessions. And when we push out information, make sure you reach out to your legislator of how this is important to you. A lot of us will educate in our clinics about it. So please help us with that, because it'll save the consumer, the patient, who is what it's all about. So much money.
Yep.
Is there anything else that you learned in the board meeting that you're just like really excited about?
No, I mean, those are the main things. I think the momentum and the fair copay are the big pieces of that.
Yeah.
Do you have anything that you'd like to?
Yeah, something that I really love is when a lot of smart people come together in the same room.
Yeah.
Right. It's like, we got Betty in here, we got Katie, we got, all these different smart people. And, I'm probably the youngest one in the room, and I just learned so much from listening to the other group members, hear their insight, because there's so much I don't know. But when we come to a table of people that have all different backgrounds and people that have lived in other states and seen how other things work, the people that have connections back east that this copay bill passed, we connect with those people, and then we collectively come together as a group and we say, this is the path. This is what we're going to choose to do collectively as a profession. Yeah. And let's go. Yep. Right. The way really that we ended that board meeting was so powerful. We were like all unified, and we were like, this is where we're going. It's going to be a hard path, because if you know, in Utah, the big, beautiful bill decreased almost $200 million of funding to the state of Utah for healthcare. You think these payers are going to be super interested in us saying, here's another bill? No, but we are saying, this is great timing because you lost $200 million in funding. We're going to teach you how to save so much more. Yep. Right? This bill is not about you payers paying more. This bill is about saving you money in the long term, right? And you'll see it. You'll see it quickly, right? Is it palpable? Is it easy to measure? No. But what we're creating is healthcare. That is really what we're striving to create. And I love when people come together in a collective manner and we just get things done, you know?
Yep.
So I'm super excited for our upcoming board meetings and the things that we're going to do. The legislative session that's coming out. There's some big changes that are happening that the Office of Professional Licensing is recommending to legislation that PT should know about. You know, we talk about, you know, some variations with dry needling, no longer calling it trigger point. We're going to make some the goal is to make adjustments there.
Yep.
Possibly being able to order labs, you know, super helpful. It doesn't mean you as a PT have to do, you know, order labs, but it's an opportunity to use that. You know, a lot of us are educated in those areas, and you get to choose if you're going to utilize that tool. Also, unlimited access to imaging. Right now, we can't order CT scans or even DEXA scans, right? But allow us to order those additional types of imaging as well. So if you are a PT, if you are a healthcare provider, be aware of these big changes. It's going to really open up access for patients and allow them to get the best care possible. So, Betty, thank you for your service. Thank you for your heart. Thank you for serving all of these women and all men and women across the state of Utah. You're making such a strong impact, and for our state as well. I know being on the board is just extra work. You know, it's impactful, it's important, it's, you know, passion is there, but it is an extra job, and just appreciate all you're doing for our community.
Thanks, Brad. I appreciate you as well.